So Peter, for you, is this shockwave going to change, you think, how you approach calcium?
Well, I think as the guys have described, I think it's having it within the toolbox. I think it offers us the opportunity. I think for me, imaging up front is key, because then you can identify which best tool to choose. Because some cases are going to be better done with rotablation, some better with shockwave, some better perhaps with laser. But I think we probably will use it for more cases than we anticipate at the moment, because it's going to be appealing because it's quick, it's simple. But I think if we use it in the wrong cases, then we're going to get not such good results. Going back to the stent under expansion, we have used laser in under expanded stents quite successfully, and I think that's going to be an increasing role for shockwave as well. Clearly it's going to work. I totally agree with Colm, the effect on the polymer is going to be negligible, I think, and we can end up putting another stent in if necessary. But we have to also, as Colm suggests, understand how many pulses to give so we don't over-injure the vessel to maximise the result, and that's going to be the sort of area of studies and trials to understand how to do it best.
So that's the final word from you, Andreas. In your practice, in your elderly patients with aortic stenosis, shockwave first, rotablation first, balloon first, how do you see it kind of integrating into this very kind of demanding patient group?
I think, as we've just heard, I think we will develop these algorithms. We will find where it sits. The napkin ring stenosis, the rotablator or the laser, I think, is the way forward, because if you can't get the balloon in, you can't use the shockwave. The undilatable lesion that can take a shockwave balloon, and you can document 270 plus circumferential calcium, I think that will be the domain of the shockwave balloon in the time to come. And certainly once you have deployed a stent and the normal methods of post-dilatation don't work, you wouldn't care about the polymer in this situation. I wouldn't make it a strategy firsthand, but if you have the situation of an underdeployed stent due to calcium, then that's where it sits. I think this is disruptive technology, and I think that will find a way in routine practice in these patients.
I mean, we haven't talked about cost, but actually the cost of a stent thrombosis is really absolutely terrible, both financially and for the patient. So, I don't think there's really any question that if we can do our job better, it has to be the way forward.
Yeah, I think an underexpanded stent is really our worst nightmare, isn't it? It's the one thing that we really hate to see.
In a high-risk patient.
In a high-risk patient.
Well, with that, I'd like to thank Peter, Andreas, Colm for your participation. I hope you found this useful webcast. Thank you for your attention.